So good morning. Thank you again for coming. So this is an honor for me just to be able to present this. This is work from many of the residents who are here, and also a lot of efforts from our chiefs here, Ashish and Sean, putting this together as well. So to begin, just for the time, so this is not, from last year to this year. So again, this is the scholarly work for those who were here last year. So scholarly work from 2017 to 2018 from our residents. So this is a snapshot. We have a lot more information, but they went to 26 conferences, many who are going to American Thoracic Society in San Diego in next week. So 12 oral presentations, 95 posters. And these are probably 2/3 of the production because many are submitting as we speak. Publications, 30 peer-reviewed articles, but when you add the abstracts, I would think it's up to like 100 publications and 10 book chapters. Where they went everywhere, Orlando International, San Diego, so American Academy of Dermatology, American College of Cardiology, chest physicians, rheumatology, American Heart Association, American Society for Microbiology, American Society of Hematology, Nephrology, Thoracic Society, and Digestive Disease. And then we go into European Society of Cardiology, the Icahn School of Medicine. Many are going to be presenting at the GME Annual Research Day, which is on June 1st. Please come if you can at the Icahn School of Medicine. And then the International Academy of Cardiology World Congress, International Conference in General Medicine and Hospital Medicine, the New York chapter of the American College of Physicians, San Antonio Breast Cancer Society for General Internal Medicine, World Congress of Gastroenterology. So throughout, as you can see, in many different fields, many awards and recognitions. Again, this is a snapshot. So a number were chosen for a top 20 national abstract at the American College of Physicians. So that's a great honor. A QI project that was actually held at Thelma under Dr. Gindi, Dr. Goldberg, and Dr. Patel. Dr. Fernando Vasquez de Lara received a scholarship at the American Thoracic Society. Will be able to go to San Diego next week. Dr. Alejandro Lamar received a travel scholarship for the American Heart Association. Dr. Suti Permiti got the 2018 Young Investigator Awards for American Society for Hematology and the San Antonio Breast Cancer Symposium. Dr. Valeria Santibanez got the scholarship for the American Thoracic Society. Dr. Daniel Castaneda was a blue ribbon recipient at the Institute for Medical Education at the Icahn School of Medicine, and received the Fellows in Training Award at the World Congress of Gastroenterology. And Dr. Ilya Verheyen also received the blue ribbon recipient at the Institute for Medical Education and a Fellows in Training Award at the World Congress of Gastroenterology. Many authors, just want to make sure that everyone gets credit. So many authors represented throughout the years, first, second, third years we're talking about. Let's say that we added about 2 slides from last year. So one person in particular also here on this slide, Preeti, is going to be one of our incoming first years. So many authors here represented, and in that note, we're going to go ahead and let them speak. So from our first, let's see. So let me, I'm going to go over to the top. Sorry. Okay, so our first presenter is Dr. Ilya Verheyen. So he presented this at the Institute for Medical Education Research Day. Dr. Ilya Verheyen is one of our second years. He is graduate St. George's University of Medicine from 2016. And as you see, he's going to be applying for GI this year. So Ilya.
Thank you. Hi, everyone. My name is Ilya Verheyen. I'm one of the second years, as Dr. Zorios mentioned. And I'm presenting on the simulation-based training for diagnostic paracentesis and how it improves patient outcomes. Presented this at the IME Research Day and also at the Gastroenterology National Conference with these co-authors, Daniel Ediak, Dr. Slonia, Manideep, Dr. Matthew, and Dr. Kurtz. So thank you all for all of your help with all the project thus far. So just a little bit of background. So the EASL and AASLD guidelines recommend that a diagnostic paracentesis is done on all patients with new onset grade 2 or 3 ascites, as well as all patients coming in with worsening ascites or complications of cirrhosis. And delays in paracentesis more than 12 hours have been linked to increased patient mortality. And one study published at the American Journal of Gastroenterology in 2014 by Kim showed that delayed paracentesis increased both mortality, length of stay in hospitals and ICUs, so much so that for each 1 hour delay would implement a 3.3% increase in patient mortality. So with this, we thought it was imperative that we teach our residents, given that most paracenteses are performed by internal medicine residents, but few institutions have a formal training program. So our study was twofold. First, we implemented a simulation-based training course for all of our IM residents across St. Luke's and West to improve confidence and competence in paracentesis. And then finally, we reviewed real-world patient outcomes before and after this training. So at the simulation-based training course was held at the CAMP Center, the Center for Advanced Medical Simulation, here at Mount Sinai West, where all IM residents underwent a simulation-based training, which included a pre-course reading, small group discussion and teaching, and task training on the risks, indications, and techniques led by a critical care fellow or attending. And our pre-course survey showed some interesting results. So 70% of our residents had only done 0, 1, or 2 paracenteses. Of that 70%, 40% had done 0 paracenteses. Only 31% felt moderately or completely confident. 14% had prior hands-on training, and 47% felt that they had to delay paracentesis prior due to lack of certification. The second part of the study was looking at the patient outcomes. So a retrospective review was done on all patients with ascites admitted to both hospitals in the medicine teaching service in 2 12-month periods. So a total of 688 charts were reviewed. In the pre-simulation based training cohort, there were 376 charts. 4 were excluded due to missing data. 372 total charts met the inclusion criteria, of which 89 paracenteses were performed. 23.6 of those were done by internal medicine residents. In the post-simulation-based training course, again, 308 charts were reviewed and 65 procedures were performed, of which 34% were done by the IM residents. And now to the good stuff. So the patient outcomes. So the mean time to paracentesis decreased for residents after simulation-based training from 49 to 39 hours. The mean hospital length of stay and in-hospital mortality decreased in the resident cohort from 15 to 10 days and 19 to 9% respectively. The development of acute kidney injury significantly decreased in the resident cohort from 47 to 18% with a p-value of 0.04. And residents performed more paracenteses after simulation-based training from 23 to 33%. So in conclusion, implementation of a simulation-based training paracentesis course increased the number of procedures performed by residents with improved outcomes in higher acuity patients, including significantly lower risks of AKI and trends to decrease time to procedure, length of stay, and in-hospital mortality. These findings may be a result of education, confidence, awareness, and skill acquisition during these training courses. So just to quickly touch on the strengths, limitations, and future direction, most importantly, of the study. I mean, the big strength here is that shows that education seems to work and that hands-on training is effective. But the limitations are we had this pretty small sample. Although it was a whole 1 year period before SPT and a 1 year period post SPT, we saw that only 89 paracenteses were done pre-SPT and 65 post-SPT. I mean, there's many factors that can play into this. Was it in the ED? Was it in the ED that it was busy? Did they do an ultrasound and was there no pocket? Did the patient not meet indications? They may have had the title of ascites on admission, but maybe it's been there and it's grade 1. Or maybe they just came from their outpatient GI doc and just had a paracentesis and referred to the ED. So that number, we have to find out more about why that is the case. And then the future direction. So we saw the pre-training survey results. We should do a post-training survey result to see how our residents felt, let's say 1 month and 6 months after the training, see if they still felt that they had the skills they needed. We should do continued sim sessions, potentially implement a standardized bedside ultrasound on all patients coming in with ascites, at least whether it's done by the ER resident, the IM resident, or IR resident. In addition, we can look at propensity matching our pre and post patient data, making sure that we have a similar patient cohort. And that's it. Any questions?
Dr. Suri, I'm 1 minute questions.
Oh.
At the beach.
No, in between each.
So I have one. Ilya, did you look in terms of the number completed? Which is my question. When you,
Sure, yeah.
Did you look to see if that 69 and 80 some odd
Mm-hmm.
was consistent with recommendations, or was that lower in terms of people that present with, the folks that should get paracentesis?
Yeah. So the question was if our data with about 89 and 65 patients respectively having gotten a paracentesis of about 350 charts that were reviewed, I mean, it's hard to say if this is among guidelines because we don't know clinically. We didn't all see the patients. This is all from chart review. So it's possible, like I mentioned, that some patients may have had not enough ascites to tap, no pocket. So whether it's guideline, I can't say, unfortunately. Any questions uptown?
No.
All right, thank you.
So our next presenter is Dr. Shruti Paramenti. So she presented this work at the American Society of Hematology in Atlanta, Georgia. She is one of our first years. She's a graduate of Patel Medical College and Hospital, India from 2014, is interested in hematology oncology. So this is many of her work. This is one abstract that she has done in many projects just in her first year.
Good morning, everyone. Thank you for being here. As Dr. Osorio introduced, I am Shruti Parameti. I just read online that a famous personality from New York just very recently told that it takes approximately 5 to 6 weeks for him to prepare for an impromptu speech. And here my chiefs just gave me 3 weeks of preparation time for this big day. So please excuse me if I make any mistakes. So I would like to talk about a research project that I worked on recently. It's called Trends of Outcomes with Different Treatment Modalities in Hodgkin's Lymphoma. And a big shout out to Qian, who is currently in China, without which this and many other projects of mine would not have been possible, and to all of the other co-authors, and especially Dr. Sarah and Dr. Citrin. A little bit about the background of Hodgkin's lymphoma. It is one of the most common types of cancers among adolescents and young adults, and it is one of the highly curable cancers in 2018. Looking at the incidence, the number of new cases have remained pretty steady over the past 40 years, and the number of deaths have been decreasing. And looking at 5-year survival rates of Hodgkin's lymphoma, it increased from 69.5% in 1975 to approximately 85% right now in 2015, according to the most recent data. So the approaches to treating Hodgkin's lymphoma have changed dramatically from the late 1800s to till date. So it was initially surgery where they just removed excessive tissue, followed by chemotherapy with arsenic in the 1890s. And then mustard-based therapy was used in early 1900s. In 1940s, radiotherapy was introduced as one of the treatment modalities. And Hodgkin's lymphoma was one of the first cancers for which combination chemotherapy was used, and it was also one of the first cancers for which combination modality of treatment was used, where they used both radiotherapy and chemotherapy for treating the disease. In this era where we are moving to chemo-free therapies, personalized targeted treatment approaches, there are very limited number of large-scale observational studies that address comparison of survival outcomes between various treatment modalities. Which brings me to my next slide, the objective of the study, which is to examine trends of outcomes in Hodgkin's lymphoma with different treatment modalities. We used United States National Cancer Institute SEER database, Surveillance Epidemiology and End Results 18 database, and included primary Hodgkin lymphoma patients diagnosed between 1985 to 2014 excluded patients with unknown or unspecified race, patients with survival less than 6 months from the date of diagnosis, patients who are lost to follow up, who developed second or later primaries. We used chi-square analysis and Cox proportional hazard regression using SAS 9.4 software to perform our analysis. This is a table depicting baseline characteristics of the study population, and I included only these variables in the slide because they are shown to be medically and socially determining the health. So the characteristics are representative of US population who are developing Hodgkin's lymphoma in general, according to the epidemiology of Hodgkin's lymphoma in National Cancer Institute and the Centers for Disease Control and Prevention website. The sample size was approximately 39,000. This is a slide showing the trends or percentage of different treatment modalities for Hodgkin's lymphoma classified into different year groups. So as we see, no patients who didn't receive any form of treatment decreased from 12 to 10%. Patients who just received radiotherapy decreased from 36 to 3%. And patients who received chemotherapy increased from 34 to 58%, and patients who received both treatment modalities increased from 16% to 37% by 2004, and decreased slightly to 28% by 2014. As I mentioned earlier, we used Cox proportional hazard regression to determine hazard ratio of death within 5 years of diagnosing Hodgkin's lymphoma, and we adjusted for confounding factors based on prior literature review for medical and social determinants of health. And we see that the combined modality with radiotherapy and chemotherapy has a significant impact on the survival. The hazard ratio of mortality is 0.55, which means there's 45% decreased risk of death in patients who are treated with combined modality in comparison with patients who didn't have any treatment, as that was our baseline. And looking at the other variables, African American race, increasing age, advanced stages by Ann Arbor staging, presence of these symptoms, and are significantly affecting mortality. So combination therapy, as I stressed earlier, was associated with 45% decrease in hazard ratio of death compared to those who neither had radiotherapy or chemotherapy. African American race, advanced disease stages, B symptoms were associated with poor outcomes. And in the years 1985 to 2014, the percentage of patients receiving chemotherapy increased from 34.7% to 58.3%. So conclude, among all Hodgkin's lymphoma patients diagnosed between 1985 and 2014, combination modality was associated with decreased mortality. We even performed year-by-year analysis to check the hazard ratios of death, and that still favored combination modality compared to single modality. And as I mentioned earlier, similar mortality benefit was not observed among patients receiving single modality of treatment. And though the use of combination modality has been decreasing over the past 2 decades, a significant lasting survival benefit was still observed. So taking this forward, I'm not sure if everyone's familiar with the famous Cleopatra trial for breast cancer, where they used both immunotherapy and chemotherapy for treatment, which offered significant survival benefit, and the trial had to be prematurely stopped because of the benefit that we observed. And here we're talking about combination modality between chemo and radiotherapy, but then brentuximab is recently approved for the use of Hodgkin's lymphoma, and we never know, but combination modality with either chemo or radio for brentuximab, chemo or radiotherapy for Hodgkin's lymphoma with brentuximab might have significant survival impact. I would like to conclude by asking one question. How many of you have read the book Emperor of All Maladies by Siddharth Mukherjee? So in that book, he has this quote by a famous physician called, "In God we trust, rest others must bring data." With this, I would like to open the house for discussion. Any questions? Any questions uptown? Yes. Because our endpoint was to look at hazard ratio of death within 5 years of diagnosis of the disease, and including patients with less than 6 months of survival would bias the study significantly. Thank you.
So our next presenter is Dr. Joseph Sassine. He presented this work at the American Society for Microbiology in 2018. He's going to be one of our future chiefs, and he's a graduate of Lebanese American University from 2014. So Dr. Sassine.
Good morning, everyone, and thank you for your presence. So today we're going to talk about the big antimicrobial stewardship initiative that we conducted here at Mount Sinai West under the lead of Dr. McKinley, who's the chair of the Antimicrobial Stewardship Committee, and with the participation of Dr. Matthew from the Palm Crypt Division, Dr. Stavropoulos from the ID Division, and of course Dr. Farkas, our ID clinical pharmacist here at Mount Sinai West. And we essentially implemented a new strategy for risk assessment for patients with community onset pneumonia that ultimately affected the kind of antibiotics they received. So as we remember, probably in 2005, and this is what at least my class and the generation of physicians that trained around my time has been taught in medical school, that HCAP, or healthcare-associated pneumonia, which is a pneumonia that happens while you have been in contact with healthcare in the past 90 days, predisposes patients to multi-drug-resistant organisms, including MRSA and Pseudomonas, and would require those patients to get such a broad empirical coverage when they get admitted for pneumonia. So, and this was endorsed by the IDSA and ATS pneumonia guidelines back in 2005. And this has led to an increased overutilization of broad-spectrum antibiotics with resultant increased cost, increased length of stay, increased drug toxicity, increased rates of C. diff infections, and increased rates of antibiotic resistance. And these have all been demonstrated in studies that have happened after this 2005 pneumonia guideline. And many patients with what was defined as healthcare-associated pneumonia, or HCAP, turned out not to be at risk for multi-drug-resistant organisms. And this outlined the need for individualized patient risk assessment, and this was acknowledged actually in the 2016 IDSA and ATS HAP-VAP guidelines, which are hospital-acquired pneumonia and ventilator-associated pneumonia, and they essentially put the concept of HCAP aside, and they said they were going to readdress it in their community-acquired pneumonia guidelines, which have been expected for more than a year now, hopefully by the end of 2018. So among those studies that looked at patient risk assessment, one particular score stood out, called the DRIP score, excuse me, or also stands for drug resistance in pneumonia. And this showed better performance than the HCAP criteria and other predictive methods. And the study group showed that a cutoff of more than 4 on this index differentiated high and low probability of multi-drug resistant organisms with remarkable precision. And this is what the DRIP score includes, really. It's mostly a lot of those were actually HCAP criteria, except that now they are weighed differently in the score, and that you don't need one of them, you're going to need at least 2 of them to be able to gather 4 points for your patients, including antibiotic use in the past 60 days, residence in long-term care facility, tube feeds, prior MDR infection. This gets you 2 points. Or if the patient has been hospitalized in the past 2 months, has chronic pulmonary disease, poor functional status, is on chronic gastric acid suppression, receives wound care, or has been colonized with MRSA in the past year, and that gets you 1 point. So the highest score is 14, and anything up 4 or above would put your patient at high risk for multi-drug resistant pathogens as a cause of their pneumonia. So what we did here at Mount Sinai West is that we looked at 102 adults who were admitted for community onset pneumonia, and we defined community onset pneumonia in opposition to hospital-acquired pneumonia, as in pneumonia whose symptoms started in the community. These 102 adults were essentially, those 102 admissions were spread between the usual care group, which was diagnosed with HCAP and received treatment per HCAP standards, and the revised care group, which ultimately underwent an antibiotic approval process that was based on a risk assessment strategy using the DRIP score, following an algorithm that was developed by the Antimicrobial Stewardship Committee. And through which antibiotic approvals were essentially requested from either the ID clinical pharmacist or the infectious disease fellows. And the primary outcome that we looked at was the total days of therapy using broad-spectrum antibiotics, including anti-Pseudomonal and anti-MRSA therapy. And the secondary outcomes were 30-day all-cause readmissions and time to clinical improvement. And we used different statistical analysis tools, including a multivariable regression model. So these are our patient characteristics. So we ended up with 46 patients in the usual care group, HCAP standards, and then the revised care group had 56 patients. Most of them were male. The age was around the 70s, and we can see a good proportion of them had some comorbidities, including cardiovascular disease, chronic pulmonary disease, chronic kidney disease, and prior IV antibiotics were the most common comorbidities. There was no statistical difference between the two groups and any of those baseline characteristics. And so we also looked at their creatinine, baseline serum lactate on admission, and the proportion of patients who had an elevated DRIP score and the pneumonia severity index score. And then, as you can see, very few culture positive sputum organisms were able to collect, essentially. And then a few of our patients had sepsis or required invasive mechanical ventilation on admission. And as far as the treatment and outcome is concerned, so actually this should have been shifted down, where we can see that the anti-Pseudomonal days of therapy and anti-MRSA days of therapy have significantly been reduced in the revised care group, and we're going to talk about that in a little bit. So we essentially looked at the days of therapy for anti-Pseudomonal antibiotics, as in cefepime or Zosyn or carbapenems, and anti-MRSA, essentially vancomycin. We did look at the length of stay and then the days of clinical improvement, as evidenced by a patient being afebrile, white count leukocytosis resolving, and then documentation by the treating physician in the charts. So this is the primary outcome was the anti-MRSA days of therapy and anti-Pseudomonal days of therapy. And with our intervention, we're able to reduce the anti-MRSA days of therapy by 1.44 days. And this was shown to be statistically significant, as well as anti-Pseudomonal days of therapy by 2 days, essentially. So we did reduce the overall antibiotic utilization of those broad-spectrum antibiotics. For the time to clinical improvement, our intervention did not delay clinical improvement. There was no statistical significance between the two groups. And for the 30-day all-cause readmission, actually there was a trend to a lower rate of readmission among our revised care group, but it wasn't statistically significant. So we can say with a lot of confidence that our intervention did not increase the readmission rate. And this is like all-cause readmission, even for like things other than pneumonia. So as a conclusion, implementation of a stewardship-driven, DRIP score-based risk assessment of multi-drug resistant organisms in community onset pneumonia did reduce the use of broad-spectrum antibiotics without increasing adverse clinical outcomes. And based on that, we rolled out the community onset pneumonia local guidelines for our hospital that are available on the internet, and we encourage everyone to essentially use them on their daily practice. Any questions? Questions uptown? Questions here downtown?
Joseph, can you repeat my question for me?
Sure.
Can you comment, Dr. McKinley will appreciate this question. Can you comment on the experience you had of resistance to using the new scoring system?
Dr. Stewart is asking about whether there's any resistance to using the new scoring system. It is, of course, in the very beginning, people will ask questions, but then when those questions are appropriately answered and there is a good solid evidence, whether in the literature or from our daily practice, I think things have been more streamlined now. Essentially, the use of broad spectrum antibiotics, especially here at Mount Sinai West, with the 72 hours stop order for vancomycin, and then the required approval for anti-pseudomonal agents, essentially is really well controlled by the infectious disease department, the clinical pharmacist, and the fellows. And everyone who prescribes any of these antibiotics will be asked, why do you need this antibiotic? What is the drip score for your patient if they have pneumonia? And do you really need those antibiotics? And then we'll need to seek approval for them. So I think from a stewardship perspective, the checks and balances are in place already. Thank you.
So our next presenter is Dr. Hamid Dakardi. So he is going to present his work from a collaboration that was presented at European Society of Cardiology Congress in Barcelona. He's a graduate of Hamadan University of Medical Sciences, and he's going to be going on to University of Kansas for a cardiology fellowship. So Dr. Dakardi.
Good morning, everybody. Thank you very much, Dr. Osorio. First of all, I want to thank the selection committee for giving me the opportunity to present this work, and I also want to thank every single one of my co-authors. Without them, this project was impossible. The title of our project was Comparison of Inpatient Mortality Trends After Myocardial Infarction Between Men and Women. And we did that on 10-year base, and we analyzed the trend over this 10-year course. This project, as Dr. Osorio mentioned, was accepted for oral presentation and was presented by Dr. Gulita Bar in European Society of Cardiology in Barcelona last year. To give you a little bit of background, acute myocardial infarction, whether STEMI ST elevation myocardial infarction or non-ST elevation acute coronary syndrome, is a leading cause of mortality in men and women in Western world. It is well established that women have higher in-hospital mortality compared to men. And it is also well established that the trends of the mortality, at least inpatient and in-hospital mortality for acute myocardial infarction, has been decreasing with all the advances in care over the past decade. What we aimed to assess was to see the trends of inpatient mortality after acute myocardial infarction and understand whether there is a different effect, different trend for the reduction in mortality between men and women. This was a retrospective cohort study. We used a national inpatient sample for this purpose. We included women and men older than 18 years, basically adult men and women who were admitted from 2004 to 2014 with a primary diagnosis of acute myocardial infarction. We used ICD-9 codes for both STEMI and NSTEMI. The primary outcome was a difference in trend of inpatient mortality between men and women. And the secondary outcomes were rates of revascularization, whether PCI or CABG, after the acute myocardial infarction event. We used the STATA, and we ran Cochrane-Armitage tests for the trend, and also we used logistic regression analysis to assess basically the P trend, the interaction between the trends. We included, as you can see here, almost 1.4 million admissions. This is actually, it shouldn't be the patients. Admissions in the study, 39.7% were females, Again, as you can see, roughly around 416,000 patients were presenting with ST elevation myocardial infarction, and 915,000 were presenting with anastemi, non-ST elevation. The mean age in years for all cases of acute myocardial infarction was 71.6 for women and 64.8 for men. Over the course of the 10 years from 2004 to 2014, the overall mortality decreased from 7.2 to 5%. You will see the details of this data on the next slide, but the rate of PCI for acute myocardial infarction increased over this 10-year period, and the rate of CABG for acute myocardial infarction decreased over the course of this 10 years. Here you can have a quick look into the data that we have in the study. As I mentioned, the mortality for all cases of acute myocardial infarction decreased. STEMI mortality and anastemi mortality both decreased, and as I again mentioned, CABG for both STEMI and anastemi, the rate of CABG decreased in both men and women, and the rate of PCI increased for both indications in men and women. And all of these changes and all of these trends were statistically significant with a p-value that you can see here. And this is basically the our primary outcome. This graph is showing you our primary outcome. The blue bars are showing the mortality rates for females, and the orange ones are the mortality for males across the 10-year period. And the red line is showing the difference between these two. As you can see, the difference between the mortality between two genders is decreasing. And basically what's happening is both men and women are experiencing reduced inpatient mortality, but this reduction is more significant in women compared to men. So in conclusion, women with both STEMI and anastemi continue to have higher inpatient mortality as compared to men. As you can see, even in 2014, the mortality rate for women is still higher. Trends show consistent reduction in mortality in both men and women along the entire 10-year spectrum. Again, the reduction in mortality for women is significantly greater than that of men, with a P interaction, which was also statistically significant. There is increase in the PCI among both genders, but there is the difference in the trends of the PCI are not similar to the trend that we see in the mortality. So this change in mortality most likely we will not be able to explain this trend in mortality with differences in the PCI. We believe the increasing awareness of atherosclerotic coronary artery disease in women among clinicians and also among patients as well, and a growing emphasis on the guideline recommended therapy for women is at least partly responsible for this difference in trend. Thank you very much again for your attention. Any questions? We actually, okay, we have a question upon asking since the mean age for women were higher than men, whether we adjusted for the comorbidity, increased comorbidities or not. We actually adjusted our results for both the comorbidities, age, the hospitals, the type of hospitals, whether it was a teaching hospital or non-teaching hospital, whether it was a rural hospital or an urban center. And despite that, we still see that this decreasing trend, sorry.
Another question. Did you look at the actual reason for the death? I mean, it's more arrhythmia, congestive heart failure, pulmonary embolus. Why were the women dying?
We are having a question from Dr. Ali downtown Israel is asking whether we looked for the reason for the mortality in women compared to men. This is actually a limitation of the NIS. We were not able to look into the exact cause of death for the in this particular case. We might have been, I mean, there was this possibility to go into secondary diagnosis and somehow guess what caused that, but we actually did not do that particular thing. Sure, hopefully. Any questions uptown? Okay, thank you very much.
Just another round of applause for Dr. DeCordy. He was actually AC at St. Luke's Knights, and he rushed over here to present. So our next presenter is Dr. Karan Sood. So he is presenting a work that he presented at the American Heart Association in Anaheim. So he's a graduate of the All-India Institute for Medical Sciences. He's going to be applying for cardiology soon and is one of our second years. So Dr. Sood.
Good morning, everyone. Thank you for the opportunity to present here, and thank you, Dr. Osorio, for the introduction. The title of my project is Predictors and Etiologies of 30-Day Readmissions in Patients with Non-ST Elevation Myocardial Infarction. Thank all my co-authors for the contributions. So just to give a little bit of background as to why we chose this study and what was the rationale behind this study. So hospital readmissions have been a very significant source of healthcare expenditure. We also know this working as residents here that we see a lot of readmissions for different reasons. As of 2012, the Center for Medicare and Medicaid Services implemented a federal hospital readmission reduction program. And under this program, any hospital with excess readmission will be getting reduced reimbursements. As of next year, 2019, these payment adjustments would be based on 6 measured cohorts. And one of these measures is acute myocardial infarction. And that's why we were interested in doing this study. There's limited data on readmission rate among patients with NSTEMI, and there have been only 3 major single-center studies that have looked at readmission rate. And the last study was about 5 years ago. There's also limited data as to what is the reason why these patients are getting readmitted within the first 30 days of discharge. And that is the reason NSTEMI patients and readmissions in this study population is of special interest to us. Coming to methods, this is a retrospective cohort study from the nationwide readmission database for the year 2014. The reason it's 2014 is because at that time that was the only year available. Just a little bit of background about nationwide readmission database. It's an all-pair inpatient database. The data is derived from 22 different states all across the US. Each state has its own state inpatient database, and each state inpatient database collects data from about 20% hospitals in that state. And all this data is pooled together to form the nationwide readmission database. ICD-9 codes are used to capture diagnoses, procedures, and in-hospital outcomes. We included all adult patients with a primary diagnosis code of NSTEMI. We excluded patients with admissions during the month of December because we did not have readmission data from the next year. And we, of course, for obvious reasons, excluded patients who died on the index admission. We also excluded any patients who were transferred to a different hospital in the primary admission. The primary outcome for us was number of 30-day readmissions. The secondary outcome were major etiologies, major reasons for readmissions, and the predictors for readmissions. We used our trend weights to reflect national population estimates. All the data that I'll be presenting is reflected for the US population. And we used logistic regression modeling to identify independent predictors for readmission. Coming to the results, so between the duration of January to November 2014, we identified 300,000 projected admissions for NSTEMI. This is US population-based estimates. Looking at the table, so the table basically represents the baseline characteristics for the study population as a whole. And the difference in the study, the characteristics for patients who were readmitted within 30 days versus those who were not readmitted. So I just want to highlight a few points here. The first row highlights the number of readmissions. So out of the 300,000 patients that were, or admissions that were identified, about 40,000 readmissions were identified within the first 30 days. This is about 13% of the study population. I want to highlight a few points here. more than 75 years of age. So about 44% of patients who were readmitted within the first 30 days were more than 75 years of age, as compared to only 35% who were not readmitted. Similarly, with female gender, about 45% patients who were readmitted within the first 30 days were females, as compared to only 40% patients who were not readmitted within the 30 days. I want to highlight some of the major comorbidities. So there were three main comorbidities that had significant differences between the 30-day readmission population and those who were not readmitted. So diabetes, 48 versus 38%, end-stage renal disease, 8.6 versus 3.7%, and congestive heart failure, 48.6% versus 30.9%. Continuing with some other baseline characteristics, I want to focus on the in-hospital outcomes here. Again, comparing the patients who were readmitted within the first 30 days versus those who were not readmitted. Patients who were readmitted within the first 30 days tended to stay longer in the hospital during the primary admission, about 5.3 days on average, as compared to 4.5 days for those who were not readmitted. That a higher proportion of patients had acute respiratory failure in the primary admission, 9 versus about 6%. Higher rates of acute kidney injury, about 24% versus 15%. I want to further highlight two major factors here. Patients who were readmitted within the first 30 days were less likely to have a cardiac catheterization during the primary admission, only about 30% versus as compared to 42% patients who were not readmitted, and only about 28% underwent a PCI in the primary admission, as compared to 39% who underwent PCI in the population who were not readmitted. Coming to major etiologies for 30-day readmission, and this is an important finding of our study here. So about 15.6% patients were readmitted within the first 30 days of discharge with a primary diagnosis code of congestive heart failure, including systolic or diastolic. And I further want to highlight a few points here. 10% patients were readmitted with a primary diagnosis code of NSTEMI. And if you look at the top 10 etiologies, 5 of them are cardiovascular etiologies. And it also includes 2 major infectious etiologies, including sepsis and pneumonia, and GI bleed and AKI as other major etiologies for readmission. Major predictors for 30-day readmission. So the most important predictor for 30-day readmission was having more than 3 comorbidities at baseline. That gives you an odds of more than 2 for getting readmitted within the first 30 days of discharge. Other than that, end-stage renal disease, congestive heart failure, a higher length of stay during the principal admission, and major complications like AKI, GI bleed, and atrial fibrillation during the primary admission also were independent predictors for readmission. I want to highlight the last 2 rows here. So admissions to teaching hospital were associated with less likelihood of getting readmitted within the first 30 days. Also, getting a primary coronary intervention during the principal admission was associated with less likelihood of getting readmitted within the first 30 days. And the last figure here shows the distribution of 30-day readmissions after the discharge. So if you look at the 50% mark here, it's about 50% of patients who were readmitted within the first 30 days were within the first 12 days of discharge. So major conclusions from this study: there's a high readmission rate among NSTEMI patients, but 1 in 8 patients admitted with NSTEMI is readmitted within the first 30 days. Cardiovascular etiologies are the most common reasons for readmission. Older age, female gender, more than 3 comorbidities at baseline, initial longer length of stay, and major complications such as AKI, acute respiratory failure, and major bleeding, even on the index admission, are associated with independent predictors for 30-day readmission. An admission to a teaching hospital and a primary percutaneous coronary intervention on index admission is associated with less likelihood of being readmitted within the first 30 days. Thank you. Any questions?
I have a quick question.
Sure.
You're studying for a 5% increase in the odds of readmission for female gender. We see this in a couple of different studies. What do you think accounts for this gender disparity?
So I think first there are multiple factors. We've seen this in multiple studies that usually female gender is, sorry, so the question here is, the study shows 12% likelihood of female gender being readmitted within the first 30 days, and what are the likely factors that might contribute to this difference? We've seen this in multiple studies that female gender has usually been associated with worse outcomes and a higher likelihood of readmission. I think the major contributing factors are a more baseline comorbidity, first of all, in female gender, and presentation is much more later in female gender as compared to male gender. So I think those are the major contributing factors.
Your study seems to suggest that these patients with STEMI perhaps may benefit from cardiac cath within the hospitalization itself, although the etiology or pathophysiology of STEMI may not be flat rupture as
Right.
STEMI. So often cardiologists are reluctant to cath. We see these patients
Right.
all the time in the ICU where their components go up, but nobody wants to cath them. So this seems to suggest otherwise. That was one of my questions. So I was wondering if you can comment on that. Second question is, if you were to develop a chronic care model, how would you utilize this data to prevent readmission?
Sure. So the first question is, study shows basically primary percutaneous cardiac intervention as improving outcomes for readmission. And so my comment on the first question is, so I think this has been shown in recent trials. Also within the last 10 years, there has been data that a faster intervention, especially in patients who, again, not for STEMI patients, but patients who come in with cardiogenic shock, they're more likely to do better if they're intervened on earlier as compared to intervening or waiting for at least 5 to 6 days before the intervention. So I think this kind of goes along with those results, and I think it also holds true for the STEMI patient population. And I think that's an important factor to look into, why these patients are not being intervened earlier and what are the reasons they were not intervened on. As far as looking into this data, we are unfortunately limited from this database, and this should be done prospectively to kind of gather more information on this. The second question is developing a care model for these patients. I think the last table which I showed, which shows independent predictors, which is adjusted for all the major comorbidities and all the confounding factors, is an important finding here. So I think we can use that predictor model to develop a score-based system to kind of predict which patients are less likely to come back within the first 30 days. And those patients should be identified on discharge, and we can make sure that these patients are have really good primary care follow-up, really good cardiology follow-up on discharge within the first week. And that scoring system would be essential for this purpose.
That was going to be my question. So there was no data available for what was set up for them on the outpatient side, from what you could find, correct?
Sorry.
You didn't have any data on what was set up for them?
No, unfortunately, again, that's a limitation for the study. We don't have data on follow-up for these patients. We don't have data what was the first outpatient follow-up, or if they were following up with a cardiologist outpatient or not. Any questions uptown? Any questions uptown? Thank you.
So our last presentation is from Dr. Alvaro Ramos Rodriguez. So he's one of our second years. So he's going to present work that was presented at the International Conference in Internal Medicine and Hospital Medicine in Dallas, Texas. He's a graduate at the Universidad Autónoma de Guadalajara from 2015. He's going to go on, and he matched in dermatology residency at the University of Puerto Rico, but we have him for another year before he leaves. Good.
Hello, good morning. I'm Alvaro Ramos Rodriguez, PGY2 Internal Medicine. This is actually a different type of project. It's a quality improvement. And quality improvement has been pretty trendy lately, and it's actually required now for like residency programs to have some sort of quality improvement. So here's a quality improvement we did last year in Thelma, the Ryan Center. This is, for those of you who don't know, this is in 125th Street and Manhattan Avenue in Harlem. Thank you all the authors and contributors, especially Dr. Gindi, who was played a major role in this project. So I'm gonna be quick, as you guys need to go back to work, I'm assuming. So, so needs and objectives. So as we know, not just for primary care, but for every subspecialty clinic, patient no-show rates remain an important challenge for us. It is very disruptive for the workflow. It negatively affects clinic organization, provider schedules, and even have financial connotations. When I was writing this project, I came a couple of articles that cited a similar no-show rate as the one we found, and they cited a 14% decrease in revenue because of no-show rates. So most importantly, also it's bad for the patients. All the articles would emphasize how when the patients attended the appointments, they would decrease emergency department visits, and just the healthcare outcomes overall were just better. That blood pressure that we detect when we see them in the Ryan Center, the sugars, it's preventing ED department visits. So we as physicians have a responsibility of trying to make these patients show up to the clinic as much as we can. So what we did, it was all in Thelma Adair Ryan Center, and we kind of optimized the reminder system because we were wondering why are patients not showing up. One of the most logical things that we figured out was either they're forgetting to come. It happens to everyone. And the other thing was we wanted to give them more autonomy in managing their appointments, and maybe that way they would be more compliant with their appointments. So we explore if optimizing our patient reminder system would increase the patient show rates in the clinic. So the methods, we collaborated with our IT department. They optimized what they already had a system in 2 days before their appointment, they would send an automated text message or phone call. But we optimized that system to make it 7 days and 2 days prior, just to give them more time to make arrangements to come to the appointment. In that automated message or a text message or phone call, they could confirm, cancel, or reschedule their appointment. And then as a clinic effort, we also make sure that the phone numbers, language preference, and mode of communications were updated for every patient that came to the clinic. One of the caveats is if the patient made an appointment 5 or less days from the appointment, he will only receive the 2-day mark reminder. If they made the appointment within 48 hours, they would not receive any reminder. And however, if they didn't show up or missed the appointment, they were given an option of rescheduling the appointment. So pretty much like giving control to the patients over their appointments. The patient that did the appointment within 48 hours or 5 or less days were also included in the study. So these were the results. We collected the results from January 2016 to January 2017, and our intervention was right in the middle in August of 2016. So we collected data pre-intervention 6 months before, post-intervention 6 months after, and we compare it. Our results were also subdivided between residents and preceptors. We're usually 1 or 2 preceptors and like 3 or 4 residents in each clinic. So this is the table that we initially did for the project. However, we have a graph that shows the results better. So here we can see the pre-intervention rates, and this is the post-intervention rates after we did our reminder system. The blue is the patients that showed to the clinic. The orange is the patient that did not show up. These are for residents, these are for preceptors, and post-intervention the same. So we saw that for residents, 3,046 patients show up, but 1,129 patients did not show up, for a no-show rate of 27%. And for preceptors, lower numbers overall, 1,661 and 745 patients did not show up, a no-show rate of 31%. After our intervention that we collected the data for 6 months, we found that there was not a significantly decrease in no-show rate. Even though we have less patients here, but there was only a 1% decrease in no-show rates for residents and a 2% decrease no-show rate for preceptors. So, and we did see a large amount of patients during this 1 year. It's almost 7,000 patients for the residents and like around 3,000 patients for the preceptors. So the discussion, when I was looking to the literature, there's a lot of papers about no-show rates. More or less, the numbers are through 30 to 80%. But many papers did found a 31% no-show rate in their findings. Our no-show rate are in line with this prior study, and our intervention did not significantly impact the pre-intervention rate. So we suggest that we can direct our efforts toward improving patient education and communication. These are ongoing projects that are trying to increase the show rate. Implementing and optimizing the patient navigator system. For us, that can be a little more difficult. We are in a low socioeconomic population in Harlem. Many of them don't have computers or access to internet as other populations. So in conclusion, even though this was a negative finding, I think it's important also to report negative findings in the literature. They're as important as positive findings. So we found that sending additional reminder system via phone call or text did not significantly increase the show rates in our clinic. Further studies are needed, like I said, to see if other interventions are effectively. Patient portals, there's a couple of practices that are doing penalties for no-show rates. Obviously, we can't do that because of the nature of our funding in our clinic. But definitely more studies need to be done to further see what can be done. This is the poster that we presented. And that's it. Thank you very much.
Were you guys able to see if they were the same patients that were no showing, or was that?
Right. So the question here is if the no-show were the same patients. So the way we did the results, we contacted the IT department and they send us the numbers. I believe that was not stratified, like a same patient could not show twice and be accounted as 2 times.
Just one question of clarification and then one real question. When you say telephone call, do you mean an actual voice exchange, or is that actually voicemails?
It's just an automated call. So basically press 2 if you want to reschedule the appointment. My
question is, did you confirm that patients actually saw the text or got the...
Yes, so actually when we open our EMR, the ECW, you can see, oh, sorry. So the question Dr. Seward made is whether we will confirm if the patient received the text or the phone call. So in the EMR, actually, with the automated system is connected to the EMR computers, every time the patient answers or sees the text, I would see in my computer answered phone call or received text message. And that was the way we could confirm. And actually, it still is like that. So when I see that they answered the phone call, usually I expect those patients rather than when they don't answer. Any other questions? Questions uptown? Thank you very much.
So I just want to thank all of our presenters. I also want to thank all of the mentors who spent the time to kind of mentor these projects along. Dr. Osorio wanted to show you the stack of all the research that has been done by our residents. They've had over 140 abstracts this year. And I wanted to thank Dr. Osorio for all the time she puts in, and Ashish and Sean to be our research kind of mentors as well. So thank you all. And Dr. Seward for supporting all these kind of trips to meetings and everything.